I'm just back from Vienna, where I attended the Vienna Lung Failure and Transplantation Symposium. And my topic, which was I was asked to speak about, is fostering European collaboration in pulmonary hypertension. So just a few words to introduce myself. For those who don't know me, I'm a former pulmonary arterial hypertension patient, diagnosed in 1988 when there were no treatments, no expert centers, no clinical guidelines, not even internet, so very little information. The disease progressed in my case, and apart from a year and a half with Flolan to bridge, I had to have a double lung transplant 23 years ago, and in fact it was precisely in Vienna at the General Hospital with Professor Klepetko and his team. I've been a patient advocate since 2001 with different organizations. I'm the co-founder and president of AIPI, Italian Pulmonary Hypertension, and as you kindly said, also Secretary General of the Alliance. My professional activity is in communication and event management. I've been doing this for about 30 years. So today I'm going to talk to you, I'll give a brief overview of the symposium, so the scientific part, even if my particular talk was more about collaboration. So referring to that, I will talk about the PH community and the key features that make it quite unique in the rare disease world. I will give examples of collaborative activities in PH care and collaborative activities in lung transplant, and then I have some concluding remarks. So this is a brief overview of the scientific topics that were covered at the symposium, which are very important, of course, because lung transplant is extremely relevant to our patients because it is the treatment of option when the other treatments have failed, and in particular, the most powerful type of treatment. So currently, the new standard of care is double lung transplant. The less common are single lung transplant and living lobe donor, although there are cases. Now, the donor pool is a big problem. As you all know, there's a huge demand for organs and there's a big gap in this demand. So a number of actions to increase the number of organs were discussed during the sessions. And one of these in particular, which is ex vivo lung perfusion, which allows us to regenerate organs that perhaps would not have been accepted previously, but which can really be transformed and become excellent donor organs. The case was made also for earlier referral to lung transplant based on data with clinical outcomes. So the case was made for changes to be made in the next treatment algorithm to move it up in the algorithm. Another very important point was that the number of procedures of a center correlates very directly with clinical outcomes. So the experience is vital to ensure that patients do well afterwards. What I found from a patient point of view very important was that there was a lot of attention paid to quality of life issues and well-being of patients. For example, pain management. There are some new techniques which were shown that can relieve pain post-transplant, in particular between the ribs, based on cryotherapy. Cryotherapy means extreme cold. And this could help avoid using opioids, which sometimes in post-transplant lead to addiction. Another point that relates to well-being of patients is ventilation. There were discussions on how to modulate mechanical ventilation better to avoid harm and discomfort. ECMO, for those of you who don't know the acronym, is extracorporeal, I forget the word. Anyway, it's about having oxygenation process go through a machine and not through your own lungs. And this is increasingly used also in replacement of mechanical ventilation with excellent results, both for bridging to a transplant and post-transplant. And today, once the machines were huge, now there's improved patient mobility. And there were a lot of very interesting sessions also about the future of lung transplant, which are very promising, including gene therapy, personalized care, so adaptive immunosuppressants based on the patient's specific conditions, genetic editing in donor organs, and xenotransplantation, which is harvesting organs from animals. And in particular, this is quite advanced with kidneys and heart coming from genetically modified pigs. This is a slide where Professor Klepetko, who presented the lung transplant program, shows which are the different activities that are needed to increase the donor pool. So legislation, extension of the criteria, active donor management, size reduced transplant, living donation, non-heart beating donation, and ex vivo reconditioning. In the meantime, I'll try to see if I can find what the acronym ECMO means. So I now come to the features of the PH community, which makes it quite unique in the rare disease landscape. First of all, it's had a very rapid evolution. There's been huge advances in a relatively short time, 25 to 30 years, in terms of creation of expert centers, research, treatments, treatment management, surgery, and patient association representation. I was diagnosed 36 years ago, so I've seen actually all of this happen in my own patient journey, and it's been very exciting to see how this progress has benefited patients in so many ways. It's a very focused community because it's focused on the rare forms of PH, PAH, pulmonary arterial hypertension, as the first drugs approved were for this rare form, and CTEPH, where surgical solutions are available and are very successful. It's a multidisciplinary community because it includes different specialties which are needed to address the different forms of PAH care. So congenital heart disease, HIV, scleroderma, substance abuse, and in surgery, because we have lung transplant, but we also have balloon pulmonary angioplasty and pulmonary endarterectomy for CTEPH. It's a close and relatively small community where everybody knows everybody, healthcare professionals, patients, patient representatives in industry, and it's well connected because there is regular convening through the scientific society congresses, European Society of Cardiology, European Respiratory Society, European Society for Organ Transplant, the World Symposium on PH, and so on. And also through industry and other events. Now, all of this, the fact that it's close, well connected, and very focused, has meant that there's been very rapid dissemination of new research, treatments, and best practices globally. So how does European collaboration in PH actually play out? So there are collaborations between different patient associations that conduct joint awareness campaigns, who prepare policy papers. The PH Patient Charter is another example. Between healthcare professionals, we've heard lots of examples today, in research, scientific papers, conferences, educational training programs, EU-supported networks like ERN Lung, informal knowledge sharing exchanges across borders. We heard today also about the International Registry from Dr. Bogard. There are also interesting collaborations between patient associations and healthcare professionals through the scientific societies, foundations, and research institutes. And of course, we all have collaborations with industry. For patients, it's through patient advisory boards or steering committees and expert panels. For the industry, it's clinical trial collaborations, research grants, and advisory boards. And Symposium and the international congresses bring together the entire community, so all the stakeholders. I'm now going to give just a couple of examples of successful collaborations. First of all, in PH care, and then in lung transplant. So World Pulmonary Hypertension Day, we've already heard about it from Yeva, which was founded in 2012 and has become a global event, bringing together 80 associations on average each year. It's coordinated by PHA Europe. It has a unified look with a common theme and branding. And it has the involvement of patients, healthcare professionals, health authorities, and industry. Other occasions on which the patient community comes together are Rare Disease Day, which is on the last day of February every year, European Organ Donation Day, which is in October, and CTEPH Awareness Month in November. Collaborations between healthcare professionals and patients started in 2018 in the European Society of Cardiology with the creation of the ESC Patient Forum. Now, this has provided the opportunity for members of the Patient Forum, and in particular myself and Gergely Messaros, to participate in the development of the last ESC-ERS clinical guidelines. The work on these went on from 2020 to 2022. It was the first time ever that patient advocates were co-authors of the clinical guidelines. It was myself and Gergely, as you can see from, this is the article. I'm not sure that my mouse works as a pointer, but you can see our names with the other 37 top experts from the entire world. Now, being a member of the Patient Forum also gives you the opportunity to speak at ESC congresses. This is an example from the London Congress last year, where I was asked to speak on the inclusion of the patient perspective in new clinical trials in PH, and also co-authorship of articles, ESC PH quality indicators being an example, and participation in different committees. So you can see a very strong collaboration with doctors through the European Society of Cardiology. More or less the same thing is happening with the European Respiratory Society. The collaboration here started in 2023 when the ELF Patient Advisory Group was formed. The PH Patient Advisory Group was created. The ERS provides support for the organization of our initiatives, including the PH Question Time webinar, which was held in 2023. And it gives the opportunity to speak at ERS congresses. Again, there was a session last year at the ERS Congress in Vienna, where I was able to speak about the World Symposium on Pulmonary Hypertension and my role in it. And it also allows you to take part in ERS task forces. There's one currently working on pH at altitude, just started. And here you can see the members from all of Europe, and there's also a member from the United States. This is my last example of collaboration with the scientific societies. The World Symposium, a very important event. It's the key scientific event in the world on pulmonary hypertension, and it's been held every 5 years since 1988. In 2018, for the very first time, a task force on patient perspectives was created to allow for the involvement and collaboration with patients. The task force in 2024, so the very last one, was composed of 4 patients. You can see them in the picture here, and 4 healthcare professionals. This collaboration led to the development of a paper, this one here, which was presented at the plenary session. And in fact, we were asked to make the opening speech, whereas in 2019, we were the last to speak. So big improvement there as well. And this paper is part of the published proceedings of the work of the 50 task forces that make up the World Symposium. Very important collaboration. Now, the example of collaboration on lung transplant comes from the data that were presented in Vienna in the last few days and relate to the Vienna Lung Transplant Center. This program started in 1986. There were 3 years of preparation, and the very first lung transplant took place in 1989. This is Professor Klepetko speaking, who was the surgeon who operated me. So this meeting actually was very special for me for many different reasons. Today, the Vienna Lung Transplant Center is among the most advanced in the world. It has held educational programs that have helped train hundreds of healthcare professionals worldwide. And very importantly, it has acted as a hub to expand lung transplant programs in Eastern Europe, where there was a vast unmet need. Today, lung transplant survival at the Vienna Center at 10 years is 78%. So there's also been huge improvements in survival statistics. A few words about the Vienna training and education programs. It has a leading role today as a leading teaching center. It has created a transplant academy, which lasts 1 week, and there are 2 courses yearly. But aside from this, there are fellows that come and are trained not only during the patient academy. And between 1995 and 2024, there are over 200 healthcare professionals that have been trained. They are trained in surgical training in operating theater, and they have hands-on experience in lung transplant procedures. And there are capacity building possibilities for people who want to set up a lung transplant program in their own country. Very new, just started, a collaboration between the Vienna Transplant Center and Toronto, which also has a very, very important lung transplant program. I think this is my last slide. Yes. So this is another very, very important activity that the Vienna Transplant Center has done, which has saved thousands of lives. It has helped develop lung transplant programs in Eastern Europe, which was largely without transplant capabilities. So these are the dates: Czech Republic, 1997, Estonia 2014, Hungary 2015, Slovenia 2018, Greece 2019, Croatia 2021, and Ukraine 2023. So a hugely successful program. Whoops, I skipped my conclusions. Here they are. So to conclude, the PH community has achieved remarkable growth in just 25 to 30 years, especially for a rare niche disease. It is highly specialized, focused, close-knit, and well-connected. Multi-stakeholder collaboration between patients, clinicians, surgeons, researchers, and industry has become the norm. This collaboration has accelerated knowledge and innovation with significant progress. We've gone from one treatment in 2000, and I know very well because it was nothing when I was diagnosed, to 12 treatments today, and lots more in the pipeline, plus breakthrough surgical techniques. So collaboration drives progress. I think this is my key take-home message. And all of this translates into tangible benefits for patients and families, improved survival, better quality of life, and a supportive global community. Thank you for your kind attention.
Thank you, Pisana, for that excellent presentation. And Louise has a question if Vienna is still accepting patients from countries that don't have a transplant program themselves?
Very good question. Unfortunately, they only do it now on a case-to-case basis, mostly for children, because there's a new policy in Austria called Austria First, ring a bell, so that in general, at the hospital, it will only take patients from Vienna, not even from the other regions in Austria. So this is something new and unfortunately very, very sad for us as patients, because many of us here, many of us in the community have benefited from the exchange programs, including myself. I was on a waiting list in Italy for almost 2 years, and I was able to switch to Vienna, where I only waited 1 month, and actually that's what saved my life.
Wow. Well, I hope as quickly as that policy came in to not have people from other countries be part of the transplant program, it can quickly go away with other people in charge. Yeah, that's unfortunate, but I hope it can swing back in the right direction.
Well, I think with the training programs that are extremely successful and very wide-ranging, it will be possible for countries to set up their own lung transplant programs. And actually, it's preferable for many reasons, for distance to the centers, waiting time, not having to move to another country, and so on. So they are continuing with their education program, and they're not the only one, obviously, in the world. I think with further education and training, it will be possible for patients to actually have a transplant in their own country.
I liked your point.
It's going to
Yeah,
take.
it's going to take time. I liked your point about multi-stakeholder collaborations being the norm. And Louise said collaboration is fortunately becoming more normal, and she really believes in these partnerships. And yeah, that's in one sense, in a way where the PH community is quite advanced compared to some other disease areas, where even when you suggest multi-stakeholder partnerships, industry especially, I think can not be so interested in taking part there and be more hesitant. So that's good to see that it's the norm, and hopefully will continue to be. And what are some of like the success factors in those collaborative projects? I mean, is it something as simple as making sure there's real, authentic patient involvement in all the decision making and on the board? Or is it, just meeting face to face regularly? But you gave quite a few examples, and what makes the good ones good?
The good collaborations, I think what makes them good is that patients are now more empowered. So there's been a gradual trend towards better patient empowerment, also thanks to the rise of internet, because that has allowed patients to connect, to have information on a scale that was previously impossible, and also it could use the learnings from all the civil rights and breast cancer and HIV movements, the grassroots movements of the 80s and 90s. So all of this has contributed to creating an environment that is conducive to patient empowerment. And I think doctors have had to realize that patients are now arriving at their consultations. They have some knowledge. It might not be correct, but you can't just tell them what to do anymore. And I hope I'm not offending anyone, but that was a little bit the paternalistic view of medicine that has been like that for decades, if not centuries. So I think this patient empowerment patient associations getting stronger, having a collective voice, federations being created, where more associations are together and they can do more. I'm thinking of PHA Europe or the Alliance or the Latin Society in South America. So I hope that partly.
Yeah.
I have another example to give. For example, I've been working as a volunteer for the European Society for Organ Transplant. Until 2019, we were not even allowed to enter, to walk into the building and to attend the conference. And last year, a patient, it was myself, but that's incidental, was nominated honorary co-chair. I was asked to do the opening speech, and I was involved for 2 years in setting the program for the ESOT Congress. So you see how in a very short time, patients have been able to make a huge step forward in terms of involvement, participation. And I'm not saying that the task is complete. It's not. I mean,
Right.
there's still a long way to go. And there are things, especially in policy and legislation, that take a very long time. Advocacy takes a very long time. Awareness is easier.